evening, everyone. The White Army is privileged to have Dr. Raina Chawla, former faculty at Lady Hardinge Medical College, Delhi and KMC Mangalore. Currently, Madam is the Director and Educator at OBG Classes by Dr. Raina. Welcome to you, Madam.
Thank you.
We have Mr. Vishal Raja, final year MBBS student from IGMCRI, Pondicherry, who has volunteered to present a case of pregnancy with previous LSCS. Welcome to you, Vishal. With the Madam's permission, we can begin the session.
Yes, please, let's start.
Yeah, Vishal, you can start presenting.
Yes, okay.
All the best.
Good evening, madam. Good evening, all. This is the patient's profile. Mrs. Veena, 27 years old, wife of Mr. Ramesh, residing in Mangalore. She studied up to BSc and she is a housewife. She belongs to middle class according to modified BG Prasad scale. Her nearest health facility is PHC Mangalore, which takes 15 minutes to reach by walking. Her obstetric score is G2, P1, L1, A0. Her last date of menstrual period is 24/10/2019. Her expected date of delivery is 30/7/2020.
How come 2019, 2020? Just hold on one second. How come 2019, 2020, we are in 2022 now?
Ma'am, as per English rule, ma'am, from 9 months plus 7 days.
No. I'm saying this case you took recently, or it's an old case you're presenting, because we are in 2022. You're presenting LMP 2019, EDD 2020.
It's the old case.
It's an old case you're presenting. Okay.
It's okay.
Right. So you've not taken this case, or you have examined this patient or not?
Yes, ma'am. I examined this patient, ma'am. I think it's 2020 I've examined this patient.
Okay, you examined her 2 years earlier. Okay, all right. Okay. So she's 37 weeks. Okay. When you examined her, she was 37 weeks. Okay.
Yes, ma'am. Yes, ma'am.
Okay.
And she's booked and she's immunized. Her blood group is O positive.
Okay, let's stop here. How did you calculate the EDD? Tell me that.
According to 9 months plus 7 days.
9 months plus 7 days is how much? 24th was her LMP. 24th October. Yes. So yeah, so 9 months would be July, and plus 7 days would be
July, ma'am. Yes, ma'am.
And 7 days would be
30.
24 plus 7 is
31, ma'am.
Yeah, so these are small mistakes. It immediately strikes the examiner. Okay, these are calculations which we do every day. Why 30th? Why have you added 6 days when Nagelli's formula says 7 days? These are small things you should know. Nagelli's formula is 9 months plus 7 days, which should be 31st July. Right?
31st is yes, ma'am. Okay.
Then
next slide, please.
So how many weeks is the EDD on? How many weeks does the EDD fall on?
Ma'am, I couldn't get you, ma'am.
How many weeks does the EDD fall at? How many weeks? 9 months plus 7 days is how many weeks?
31 weeks, ma'am.
How many? Not this question. I'm saying 9 months plus 7 days is 37 weeks or something else. The EDD falls at how many weeks? The EDD falls at 40 weeks, not 37 weeks. The EDD, when we say 9 months plus 7 days, it is not 37 weeks, because each month doesn't have 28 days. And you must be thinking just multiply by 4 and add 1 week. No, you have to remember that 9 months plus 7 days is 280 days, which is 40 weeks. So EDD always falls at 40 weeks. Okay, not 37 weeks. Okay.
So okay.
9 months plus 7 days is 280 days, which is 40 weeks.
That is
okay, your patient is 37 weeks. Yeah, okay, continue.
37 weeks. Yes, ma'am. Presenting complaints, no presenting complaints, and she's admitted for safe confinement in view of previous LSCS.
Okay.
Next, history of present pregnancy. In first trimester, she has been spontaneous conception. Pregnancy confirmed after 45 days of amenorrhea by UPT at home. No history of fibrosis gravidarum, no history of fever with rashes, no history of bleeding per vagina, no history of white discharge or burning micturition, no history of radiation exposure, no history of drug intake, and she's consumed folic acid. A dating scan was taken at 10 weeks. Baseline investigations were done and found to be normal.
Okay, you've said baseline investigations were done and found to be normal. What are the baseline investigations that you would want to do?
Blood count,
In
urine
pregnancy.
examination.
Okay, urine examination. What else?
Blood count and viral test, VDRL, and
Okay.
HPSAG,
Okay.
and blood sugar level, and
Okay, repeat. You said hemoglobin, you said? Then
yes,
urine
hemoglobin,
routine
yes.
microscopy, you said? Hepatitis B antigen. What else?
Hepatitis, okay. HIV testing, ma'am.
HIV, okay. You said blood
HIV.
sugar. Okay, what
Blood
else?
sugar, ma'am.
VDRL, you said?
Then serum.
Yeah.
Yes, serum albumin, bilirubin levels. So
Why
VDRL level.
why routine antenatal testing? We don't require LFT for routine antenatal testing. Okay. What else?
So okay, ma'am. Okay.
What else in the first trimester? Part of routine antenatal testing. We already know her blood group. So if we don't know her blood group and RS typing, we should also get her blood group and RS typing done.
Yes,
Okay.
blood RS typing.
And also a urine culture has to be done. Okay.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
In routinely, which Applica has mentioned in the chat. Okay. What else?
Yes, yes.
Okay, continue.
Okay. Next slide, please. In second trimester, she has gone 4 antenatal visits. Quickening felt at 18th week. History of TD immunization, 2 doses has been received. First dose at 12th week and second dose at 16th week. History of iron and calcium supplementation has been taken. No history of bleeding PV. No history of symptoms suggestive of preeclampsia like excessive weight gain, swelling of feet, decreased urine output, headache, blurring of vision, epigastric pain. Screening test for GDM is done at normal. Mnemonics scan was taken at 20th week. Weight gain was found to be 4 kg.
Okay, you said screening test for GDM was done and found to be normal. What is screening test for GDM? What would have been done? What do you think would have been done?
A dipstick, ma'am. The dipstick test was done.
Screening test for GDM by dipstick. What do we screen? How do we screen GDM?
For GTT, ma'am, for oral glucose tolerance.
Okay, good. How is the oral glucose tolerance test done? Can you tell us the different types of GTT and what is done at your college, or what have you seen being done in pregnancy? Because there are many types of GTT. One is a WHO GTT, one is done in non-pregnant individuals. What is done in pregnancy? What is the recommendation for pregnancy? How is it done? Do you know?
100 gram OGTT was given.
So 100 gram OGTT used to be done. Now we don't do 100 gram GTT. We do
75 gram of glucose.
We do 75 gram of glucose is given. First, we take a fasting venous sample. Then we give the woman 75 gram of glucose. And then we check the sample again at 1 hour and 2 hours. Okay.
2 hours, okay.
So,
okay, ma'am.
So this is one type of screening. This is the international guidelines. Indian guidelines, which is the DIPSI, says irrespective of fasting state, she doesn't have to be fasting. You give 75 grams glucose and check the reading after 2 hours. Okay. So your homework for you is to find out the cutoff values for the international guidelines and the DIPSI guideline, Indian guidelines. Okay. Will you do that?
Okay, okay, ma'am.
Good. Okay. So screening was done. And when do we do the screening? When do we do the screening? At what gestational age?
28 weeks, 24 to 28
Around,
weeks.
Yes, very good. 24 to 28 weeks, we screen for GTM. Okay, because that is the time usually women develop GTM. Okay, continue.
Yes, ma'am. Yes. Next slide, please. In third trimester, number of antenatal visits is 5. Fetal
Just 1
movements
second.
perceived adequately.
So on the comment, someone has written all patients considered high risk initial screening followed by very good. So in fact, screening for diabetes is done in the first trimester, but that is screening for overt diabetes. Okay, that means women who already may be diabetic or pre-gestational diabetes. To check for pre-gestational diabetes, we test all women or high-risk women in the first trimester. Okay, but to screen for GDM, to screen for gestational diabetes mellitus, we screen between 24 to 28 weeks. Okay, so in the first trimester, when we screen, we can do an HbA1c, we can do a FBS, we can do a RBS. But when we screen between 24 to 28 weeks for GDM, then we always do a 75-gram GTT. Okay, I hope that's clear. Okay, third trimester.
Mr. Finite calcium supplementations were given. No stuff. Symptoms suggestive of preeclampsia, like excessive weight gain, swelling of weight, decreased urinary output, headache, blurring of vision, epigastric pain, no stuff bleeding per vagina, no stuff breaking per vagina, no stuff pain in abdomen, no stuff bowel and bladder disturbances. Weight gain was found to be 4 kg.
Okay.
Next slide. Moving into menstrual history, age at menarche was found to be 14 years. Cycles per regular, 28-day cycles, flow lasting for 4 days, and it found to be normal flow. The last date of menstrual period is 24/10/2019. No history of menorrhagia and dysmenorrhea. And next slide. Marital history, married at the age of 23 years, no consanguineous marriage. Next slide. Moving to post-operative history, parity was found to be 1. Age during first pregnancy was found to be 24 years. She's a spontaneous conception. She was booked and immunized. No history of complications during antenatal period, like preeclampsia, GDM, and antepartum hemorrhage. No history of any blood transfusion. Her place of delivery is PHC Mangalore. And delivered by emergency LSCS due to fetal distress at 13 weeks of gestation. Live birth, and it found to be term baby. She's a male child. Birth weight 3 kg. Baby cried immediately after birth.
Okay. What have you missed in this? She was age at first pregnancy was 24 years. Better than saying this, you just tell us how many years back it was done, because I don't remember her current age, and it is very important. So, how many years back was this cesarean done? Why is it important? So even you have to go and see her age. Why is this important? How many years back? So she's 27. And this was done when she was 24 years old. So this was done 3 years back. Why is it important? Why is this very, very important? In this case, why?
Whether to plan for delivery, ma'am, whether to go for a vaginal or
yes. So how does it matter? Whether it was 1 year back or 3 years back or 10 years back, how does it matter when her last cesarean was? How will it play a role in deciding the delivery now?
VBAC, ma'am, vaginal birth after trial of labor.
How? Why? How is it important? How is the interval between the two pregnancies important in deciding the delivery now? What are we worried about? If she has a previous scar on the uterus, what are we worried about?
Worried about rupture, ma'am, scar rupture.
We're worried about scar rupture. So,
scar rupture, yes, ma'am.
So how is this important? How do we know which scar will rupture, which scar won't rupture? Because it depends on how the scar has healed. Okay, how do we know this? So we can't see the scar because the scar is on the uterus. So how do we know the scar has healed? Based on different history and based on our examination, right? So based on history, how do we know? So if she had a cesarean 1 year back versus if she had a cesarean 3 years back, which scar do you think could have healed better?
I think 3 years back might be healed better.
So the more the duration between the pregnancies, the better the chance that the scar has healed, right? So that's why it's very important to know when she had her last cesarean. So it has been found Okay, so it has been found that scars which are less than 18 months old. Okay, so if a delivery has been less than 18 months, 1.5 years, then those scars have been found to be very weak and rupture uterus is more common, as against
yes.
women who have spaced their pregnancy by more than 1.5 years. So if she delivered 3 years back, that tells me that the scar is relatively okay. What are
Healed.
the other points which will tell us that the scar is okay in your history, that the scar has healed well? Based on history in your previous pregnancy or now, how do you know that the scar has healed well? Based on history in her previous pregnancy. So if think about wound healing, what are the things that will hamper wound healing? In simple, in pathology, you must have read the factors which hamper wound healing are what?
That inflammation.
Pardon?
Some.
You've asked history of blood transfusion. Why have you asked history of blood transfusion?
Because to avoid the blood transfusion reactions. So, is there any previous blood transfusion reactions that occurred? Or so
How
I
does
asked about.
reaction matter? Why have you asked history of blood transfusion? Because if she had blood loss, she would have been anemic. Anemia can affect the healing of the wound.
Healing
So if
of the
she had
wound.
history
Okay.
of anemia, if she had history of blood loss, that would hamper the healing of the wound. So that's another important thing. Whether she
Yes, ma'am.
had
Yes, ma'am.
anemia, whether she had an infection in the previous cesarean section scar. Okay, did she have fever or did she have any signs of infection, wound sepsis in the previous cesarean? That would also indicate that the healing of the wound is poor. Okay, then the interval between the pregnancies. Okay, so these are the important things that you have to ask. Okay, continue.
Yes, ma'am. Next slide, please. No step required vision. Breastfeeding started within 4 hours after birth. Exclusive breastfeeding after 6 months. No step people complications like fever, spout opening,
You've
lochia,
asked
wound
this.
gaping.
You've asked this, but you should know why you have asked this. Okay. You've asked this because if there was infection, then there would be poor healing. Again, blood transfusion, you've asked. Why have you asked this? No history of wound gaping or infection. So you have asked all these, but you should know why you are asking these things. You're asking this to know how the strength of the wound is now. Because we have only indirect evidence. We don't know directly. We don't have X-ray vision. We can't test the scar in any way. So if we are going to give her a trial of labor, okay, we need to have some evidence that this scar will withstand the stress of labor and it won't rupture. Okay.
Yes.
Okay, continue.
Switch removed on 8th day after delivery, discharged in the next day, no history of wound gaping or infection. Present age of child is 3 years. History of contraceptive use in the form of intrauterine device for the next 2 years. Next slide. Next slide.
Please change the slide.
Hello.
Would you please change the slide?
Hello. 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 Past history.
Okay, continue.
No history of diabetes, hypertension, tuberculosis, bronchial asthma, thyroid disorders. No history of any other surgery in the past. No history of blood transfusion. No history of sexually transmitted disease.
Okay.
Next slide. Personal history consumes mixed diet, normal bowel and bladder habits, normal sleep and appetite, no history of addictions, no history of drug intake or allergy. Moving into family history, no history of diabetes, hypertension, TB among the family members, no history of multiple pregnancy or congenital anomalies. Next slide. General examination, she's well built, moderately nourished, height 155 centimeter, weight 48 kilogram, her BMI 19.9 kilogram per meter square, no gait spinal deformities, no pallor rectus cyanosis, clubbing, lymphadenopathy, pedal edema. Vitals, temperature afebrile, pulse rate 84 minutes, regular rhythm, normal volume, and character, all peripheral pulses were felt, respiratory rate 18 cycles per minute, BP 120/80, measured in right upper limb sitting position. Next slide. Thyroid examination normal, breast examination normal, systemic examination, CV assessment, history heard, no murmurs, RS normal, vesicular breath sounds, no added sounds. Obstetric examination, inspection, abdomen is uniformly distended, flanks are not full, umbilicus is in midline, averted, tinea nigra and stria gravidarum is present, 10 centimeter healthy, horizontal scar present in lower segment, cough impulse at scar site, hernial orifices were found to be negative.
So you've said 10 centimeter healthy horizontal scar present at lower segment of what?
Uterus.
How can you see the scar on the uterus? The uterus is not on the surface of the abdomen. How can you see the scar on the uterus? You have X-ray vision. How can you see the scar on the uterus? Where will you see the scar? Will you see the skin scar or you'll see the uterine scar?
Skin scar.
Then why have you written lower segment? Lower segment of what? We don't know what the scar is inside. We can't see the scar on the uterus. It would have healed also. Even if you see the uterine scar, you can't make out this is the uterine scar. You can only see the scar on the abdomen. And
Lower
where will
abdomen,
the scar on the abdomen be? In a
Lower
cesarean
abdomen.
section scar, what is the scar we give? What is the name of the scar that is given in a cesarean section scar? Where in the lower abdomen? Will it be horizontal? Will it be vertical? How is the scar of a cesarean section?
It's a phalansteal.
How does a phalansteal scar look like?
It's a horizontal scar.
Where?
The lower abdomen.
In the lower abdomen, it is a scar approximately 2 finger breadth above the pubic symphysis. It's a curvy linear scar. It is not transverse. It is slightly curving. It's called a smiling incision because it is in the shape of a smile. So it's called a smiling incision. Okay, so that's what a phalansteal scar is. So this is wrong. You can't write present at lower segment because we can't see the uterus. We are only examining the patient's abdomen. Okay.
Yes, ma'am.
Continue.
Next slide. Palpation fundal height corresponds to 36 weeks. Symphysis fundal height is 36 centimeters.
Why have you taken the symphysis fundal height in this patient? Why have you measured? What is the significance of symphysis fundal height?
Size of the baby.
How can you calculate the size of the baby with the symphysis fundal height?
Whether it's a big baby or small.
How can you calculate? You've taken it as 36 centimeters. How will you calculate okay, so those of you who are watching on YouTube, please tell me in the comment section, what is the significance of symphysis fundal height? Okay, when do we measure it? Okay, and how does it help us to calculate the estimated fetal weight? This is homework for you also, Vishal. You have to read.
Yes,
okay, continue.
Okay. A fundal grip, soft, broad, and irregular non-palatable mass suggestive of breech. Lateral grip, right, irregular knob-like structure spelt, suggestive of limb buds. Left, uniformly curved, smooth, resistant spelt, suggesting of back. First pelvic grip, hard, globular, palatable mass suggesting of fetal head. It's not engaged. Second pelvic grip, hands converged. Head is not engaged and cephalic presentation. Next slide.
Next slide, please. Next slide. Yeah.
Scar tenderness is absent.
Okay.
Uterine activity is relaxed. Like amount is average. Auscultation fetal heart rate is 144 beats per minute in left spine umbilical line, and it is regular.
Okay.
Next slide. So summary. This is Raina, 27 years old, G2 P1 L1 with LNP 24/10/2018, EDD 37/2020 with 37 weeks of gestation, is admitted in hospital for safe confinement. 1 day in view of previous LSCS. She delivered by LSCS in the previous pregnancy, indicating fetal distress. She has no preserving complaints, no history suggestive of labor pain, or bleeding PV or leaking PV. She perceives normal fetal movements. On examination, there is no pallor or pedal edema. Her pulse rate is 84 beats per minute. Her BP 120/80. Obstetric examination reveals a term size uterus with a singleton live fetus in cephalic presentation. It is not engaged and there is no scar tenderness. Liquor appears average and uterus is relaxed. Fetal heart rate is 144 beats per minute and it is regular.
Okay, so what do you want to
That's
do
it.
now? What do you want to do for this patient? She's admitted for 37 weeks. But you said
Yes,
for
ma'am.
safe confinement. What do you mean by safe confinement? You're going to confine her in hospital for when? Till when? Why have you confined her in hospital?
Because for delivery of the
For delivery.
baby,
So she's admitted for delivery. So now she says, okay, doctor, deliver me. What will you do?
trial of labor.
How? She's not yet in labor. What are the options you will give her?
Whether cesarean section or vaginal.
Yes, so she has two options. You tell her you have two options, vaginal delivery or cesarean section. So she tells me,
Yes.
doctor, tell me the risks and benefits of both. What are the risks of having a vaginal delivery? What are the risks of having a cesarean section? Then I will decide.
Yes, ma'am.
What are the risks? What will you tell her? You've taken this case and she asks you, can I have a vaginal delivery? What are the points in favor or what are the points against her having a vaginal delivery? And what are the points that go in favor of her having a cesarean section? So what are we worried about? We already discussed this. We are worried about?
Rupture scar.
Yes, we are worried about rupture
Scar
of the
rupture.
uterine scars.
Uterus.
That's called uterine rupture. We're worried about scar
Yes, ma'am.
rupture during labor. Okay, so scar
Yes,
rupture
ma'am. Yes.
most commonly happens intrapartum, that is during labor. When the uterus starts contracting, the scar can give way if it is a weak scar. Okay, so what is the incidence of rupture? She asks you, doctor, if the scar can rupture, what are the chances that my scar will rupture? What will you tell her? Okay, Anjali has given the answer 1 in 200. Okay, so approximately, yes, it is 0.5 to 1%. That means if there are 100 women, one will rupture. If you have 100 women who have a previous cesarean section scar, one of them will rupture during labor. So the chance of rupture is 1%. Okay,
1%.
but if she ruptures, what are the risks? What will happen if she says, okay, doctor, if I rupture my scar, that time you do a cesarean section. So what will you tell her? What are the risks of scar? Because patients will want you to explain everything to them. Okay, and we have to explain everything to them. Okay, so you have to tell her what is a scar rupture. In simple terms, what will you tell her? What is a scar rupture?
It is a disruption of the entire length of the scar, including the peritoneum.
So that she won't understand all that. She will ask you, what will happen to me if the scar ruptures? What will happen to my baby if the scar ruptures?
Fetal will be present in the peritoneal cavity.
So will the fetus? So if the fetus goes inside the peritoneal cavity, what will happen to it?
It may lead to death.
Yeah, so if the scar ruptures, the baby will come outside, the placenta will separate, and the baby will die almost instantaneously. Yes. Okay, what will happen to the mother? What will happen to the mother? The scar has ruptured inside, baby has come out. Will the mother be fine or she'll go into some problem? The mother will go she'll have intraperitoneal bleeding. The scar will give way, she'll start bleeding, she will go into hemorrhagic shock. Okay. Yes. So it is a risk for both the mother and the fetus. Okay, and mother and the baby both can end up in severe morbidity or mortality. Okay, so that has to be explained to her. So she says, what will you do for this patient? Can she have a trial of labor or not?
Yes, ma'am, we can have trial of labor.
Okay, what are the points in favor that she can have a trial of labor? Or in other words, what are the points in favor that this scar won't give way? We've already discussed some points.
It's a previous CS, that is 3 years before, ma'am.
Okay, so it was done 3 years back. So in 3 years, you would expect that the scar would have healed.
Yes, ma'am.
Okay, then
And
she doesn't have any history of anemia. She has no
anemia.
history of
Yes, yes.
infection
Yeah.
of the wound. Okay,
No
then
history of any surgeries.
this is an
No history.
uncomplicated pregnancy. Okay, it's a term fetus. This baby looks fine. This baby is a cephalic presentation. Okay, there is no, there doesn't look like to be any macrosomia or FGR. This pregnancy is
Yes.
uncomplicated. So all these are things in favor of the scar having healed well. Okay,
Yes, ma'am. Yes, ma'am. Yes, yes,
there's
yes.
no scar tenderness on palpation. Okay, so all these are points in favor of a vaginal birth after cesarean. That is a VBAC. Okay.
Yes, ma'am.
Okay. So
That is
okay. So tell me what are the points which would favor, not in this patient in general, what are the points that would favor a weak scar? One is less interval between the two pregnancies. What else?
vaginal
What are the
bleeding.
factors? Okay. What are the factors that you will expect it to be a weak scar?
Scar tenderness, suprapubic pain.
Okay. Okay.
And
Then.
continuous abdomen pain present
Okay.
between contractions.
Okay.
And maternal tachycardia.
Okay, that's good. Maternal tachycardia. If she's in labor, maternal tachycardia is a sign of scar dehiscence. Okay.
Scar is okay.
Okay, so some of you are asking this question: How is scar tenderness done? Can you tell us how do you palpate for scar tenderness?
Gently
Where do you
palpate
palpate?
in the suprapubic region. We have to palpate, ma'am.
Yes, so very good, because irrespective of where the skin incision is, it may be a vertical skin incision or a transverse skin incision. Okay, but the uterine scar is in the lower segment of the uterus. Okay, that is, so where do we palpate? We talk to the patient. Very good, Anjali. We talk to the patient, distract her. Okay, and then we palpate right over the suprapubic area and see if she, yes, and look at her face, see if she's wincing. Okay, if she's wincing with pain, that means there is tenderness. Okay, right.
Okay.
Scar tenderness has to be checked for during a patient who is in labor. If you're giving her a trial of labor after cesarean section, that is TOLAC, then she requires to be monitored very closely. Her pulse has to be checked. Okay, so maternal tachycardia is one of the first signs of scar dehiscence. Fetal bradycardia is a sign of scar dehiscence, and scar tenderness is a sign of scar dehiscence. Okay, last question, Vishal. What is the difference between scar dehiscence and scar rupture?
In scar rupture, there is a severe pain will be present, ma'am, symptoms.
No, I'm not asking you how to differentiate. I'm just asking you what is the basic difference in definition between scar dehiscence and scar rupture. Okay, Tanvi is saying not all layers. Okay, Tanvi, which layer? Which layer will not break down in a scar dehiscence? The serosa or something else? Okay, so in scar dehiscence, okay, the UV fold of peritoneum will remain intact. So what covers the uterus? And the uterus is covered by a visceral layer of peritoneum which goes over the bladder. Okay.
Okay, ma'am.
So in scar dehiscence, that UV fold of peritoneum remains intact, but otherwise the scar has given way. But the peritoneum over it is still intact. It's keeping the baby inside. Okay. But a scar rupture, the peritoneum also gives way, and that is why when scar rupture happens, chances of bladder injury are also there. Okay. Scar, yes, on scar dehiscence, if so, all this maternal tachycardia, fetal bradycardia, scar tenderness, if you pick up and you do a cesarean at that time, you will save the baby. But if once rupture has happened, it's very difficult to save the baby. Okay, the baby will die within minutes of a scar rupture. Okay, that's why monitoring is very important of a patient who you are giving a trial of labor to. Okay.
Okay, ma'am.
Okay, Vishal, I think we can end here. Okay.
Okay, ma'am.
So I want you to do the homework. I remember the homework you have to write in the comment section. What homework did I give you?
About that,
About what?
that wound heal, scar
Yes,
healing.
very good. Cut off for GTM the values. Okay. That and I gave one more homework also. Even I have forgotten now.
Scar healing. What are the factors
Pardon?
what are the factors inherent to scar healing?
Yes, SFH, Anjali, good. So no, I asked you two homework. One is the cutoff for values of GTT, both the different types of GTT, IAD, PSG, that is international guideline, and DIPSI guideline, the cutoffs for GTT. Okay.
GTT,
And the second homework, which I want all of you to write in the comment section, is the importance of symphysiofundal height. When do we take it? Okay. And secondly, how do we use it to calculate the estimated fetal weight? Okay, Tanvi is asking a question. What ultrasound thickness is alarming for scar thickness? So Tanvi, basically when we look at the scar thickness on ultrasound, okay, first of all, it is not very clear whether it is of benefit or not. Most studies say it is of no benefit. Okay, so clinicians are 50-50 over this, whether it's actually useful or not. But if you want to do it, then we measure at the level of the bladder. I'll make a video if possible and share, okay, how we measure scar thickness. And when we measure it, if it is less than 3 millimeters is the cutoff taken to say it is a weak scar. Okay, so some books say 2.5, some books say 3. Anything less than 3 mm is a weak scar. Okay, and you should be more careful. Of course, this is just, again, not evidence-based. Most studies have said it doesn't show any benefit, but I will take a video and post it on the group. Okay, SFH used in Johnson's formula. Good, Peter. Okay, so the rest of you still post on the YouTube channel. There are many other formulas. So I want all the formulas to calculate fetal weight. Why else do we take symphysiofundal height and the cutoffs for GTT? Okay, Vishal, good effort. Okay.
Okay, ma'am.
Well
Thank you so much,
presented
ma'am.
case, but you need to read up. Okay.
Okay, ma'am.
Okay. Thank you.
Thank you, ma'am. Thank you so much.
Good night.
Thank you, ma'am.
Welcome.